So thank you very much. We'll move on to the next session. We're already half an hour behind schedule, but we'll hope to catch up as we move forward. So the next session is also proving to be very interesting. This is on thyroid. So may I request our chairpersons, Dr. Senduru Ramachandran and Dr. Sumati Ma'am, professors of obstetrics and gynecology, to take the stage, please.
A warm good morning. I feel privileged and I thank the organizers for this nice opportunity. The topic is hypothyroidism in pregnancy and update. We all know that thyroid gland during pregnancy undergoes changes in structure as well as in functions because of increased levels of human chorionic gonadotrophin, increased levels of estrogens, and altered iodine metabolism. If not properly diagnosed and managed, hypothyroidism, both overt as well as subclinical hypothyroidism, may lead to complications in the mother, fetus, and in the newborn. In pregnancy, it may cause spontaneous abortions, maternal anemia, preeclampsia, gestational hypertension, placental abruption, and preterm labor, low birth weight infants, as well postpartum hemorrhage. In the fetus, it causes neurocognitive disorders, congenital hypothyroidism, and after birth, neonatal hyperbilirubinemia and respiratory distress. So now I request Dr. Muthukumaran Jayapal onto the dais to deliver his lecture. He is graduated his MBBS, MD in UK, MRCP UK, CCT, Endocrinology and Internal Medicine, present designation, Consultant Endocrinologist and Managing Director, ARCA Center of Hormonal Health Private Limited, Chennai. Affiliations, postgraduate training in the United Kingdom, internationally accredited training in internal medicine and endocrinology. He did his research degree MD UK in diabetes and genetics. His achievements: Honorary Treasurer, Endocrine Society of India, 2015 to 18. Honorary Secretary, Endocrine Society of Tamil Nadu and Puducherry, 2019 onwards. Had several publications in national and international journals. Over to you, Dr. Muthukumaran.
Thank you, ma'am. Thank you for the warm introduction. Thank you, Madurai team, for the opportunity. I'm just going to give you a broad overview this morning about hypothyroidism in pregnancy. And there's been a few confusions regarding our TSH values, when to treat and when not to treat. And that's my task cut out for this morning. It's not moving. Thank you. So what we are going to look at is the background behind this topic is hypothyroidism is really easy to diagnose, but accurate assessment during pregnancy becomes a challenge because of various reasons. And the interpretation of thyroid function test is also different from what you do in a non-pregnant patient. And that then comes the HCG effect, which puts us into question about changing HCG, changing TSH concentrations, especially in early pregnancy. You try to catch up with the increased dose. And to complicate matters, the TSH reference ranges, both in the population and in pregnancy, have been discussed, debated all over the world. And I'm going to give you reasons why this has been done. So, and then the controversy about pregnancy is, should we screen everybody or should we just screen the targeted population? And there's been arguments on both sides for this. Some of the organizations have gone for targeted screening. Some of them have gone for universal screening, and the data behind this is, again, multiple studies, even larger studies have just failed to decide on this matter. The current advice from the international bodies is targeted screening, but we know when you do targeted screening, you can miss up to 30% of your patients. The ACE recommends, the only international body which recommends universal screening is ACE. The ACOG, the American Thyroid Association, the BTA, everybody recommends targeted screening. What do we do for detection of thyroid dysfunction? Both in pregnancy and normally, TSH is our most important test. And the TSH is the best test because it's more accurate, it's reproducible, and we've got sensitivities up to 0.01. And it is much more reproducible than your free T3 and free T4 or total T3 and T4. And we have a log linear relationship between your free T4 and TSH. I'll just skip one slide back. So this is what we mean by a log linear relationship between your TSH and free T4. There is a small change in your free T4, like for example, it moves from 0.6 to 1.2. There is a significant 100-fold difference in your TSH. So your TSH will move from 2.5 to basically above 100. So that's what. So it's very, very sensitive. It's very reproducible, and the current assays are very, very accurate. So we bank more on the TSH than your free T4 or total T3. And as you're all aware, the hypothalamic pituitary axis should be intact to make sense out of this using a TSH. So if you have a problem with the pituitary gland, then you might have to screen your T4 and TSH together. And going back, the TSH has got two subunits, which is alpha and beta subunit, which confers specificity. And there are multiple hormones which have got a common alpha subunit, and this is one of the reasons why we have pregnancy-induced first trimester changes as well. And the TSH secretion is regulated by negative feedback by the circulating thyroid hormone, and it's also got other interactions with somatostatin and dopamine. The TSH then stimulates the thyroid gland to produce your free T3 and free T4. So where do we stand with the normal TSH? We've been discussing this for some time, but the current advice is in patients with hypothyroidism, we want to keep the TSH to less than 2.5, and sometimes organizations have given us trimester-specific ranges as well. We'll come back to this in more detail. So in anybody who's attempting to be fertile, then we would like the TSH to be less than 2.5 on patients with thyroxine. We will look at it for patients who are not on treatment in the next few slides, and Dr. Sriram will also be discussing about patients who are normal thyroid levels with antibody positivity. But before you interpret the TSH gets influenced by multiple factors like age, gender. Your body mass index is a main marker. Even in young children, if they are very, very obese, their TSH can go up. ethnicity is a common problem because various populations have been noted to have different TSH ranges, and my next slide will tell you that. If you look at the Caucasian populations here, these are normal patients. These studies have been, the data has been taken from multiple studies, multiple different studies, and if you look at the Caucasian reference ranges, they are much, much different than what you would look into the Chinese or the Indian data. So here, the upper limit of normal is certainly very, very high. If you look at the first trimester ranges, if you look at here, your upper limit on the first trimester would be 2.5 in the white Caucasian people, whereas we have got like around 5 is our upper limit of normal. And this is one of the reasons why organizations have, are debating to start whether to treatment on lower TSH ranges. So this is what we are going to look at. There are instances where you need to be cautious. I've given you the physiological thing. These are the pathological areas where you need to think twice before just depending on your TSH. If somebody has got pituitary dysfunction, then you cannot use TSH just alone. Some diurnal variation is there. Patients who are on drugs like glucocorticoids, dopaminergic agents, metformin can also have a smaller effect on your TSH. There are other rare combinations like TSH receptor polymorphisms, heterophilic antibodies. They all alter your TSH. The last but most important out of this lot is your undetected adrenal insufficiency. A person with undetected Addison's disease may also have a TSH, but the most important thing is in these patients, we endocrinologists would like to start the patient on steroids prior to starting thyroxine therapy. So this is very, very important clinically. So how does hypothyroidism work? In general terms, your TSH starts going up gradually and slowly prior to your dip in your total T4 and T3 hormones. So if somebody has got mild thyroid dysfunction, then that's when the TSH starts to go up. The T3 and T4 levels will be in the normal range for a couple of years at least prior to dropping down. So these are the number of years when you move from mild to moderate to severe hypothyroidism. So moving on, that is a broad overview of the TSH and the tests what we use, but thyroid physiology in pregnancy changes all these things. So the increased estrogen level in your pregnancy will cause the thyroid binding globulin to go up. This reduces your free thyroid hormone availability, causing stimulation of hypothalamo-pituitary axis. So this is kind of in normal physiology. Your HCG, which gets secreted between and reaches a peak between 8 to 12 weeks, stimulates the TSH receptor because these have the alpha units of HCG and TSH are very, very similar to one another. So the HCG has a TSH-like activity which increases the thyroid to produce more thyroid hormone, and this is primarily related to HCG-related thyroid receptor stimulation. And then last but not the least, type 3 deiodinase increases thyroid dehydration, increases glomerular filtration rate, and there is also increased T4 placental transport. So these are all multiple changes which gives us a broad overview of the physiology in pregnancy. And then the fetal effects also are there. The source of iodine for the fetus is primarily the mother in all trimesters. Thyroxine is partially converted to T3, which is responsible for fetal brain development as early on. Up to 12 weeks, the fetus is primarily dependent on the mother's thyroxine level, and this becomes important to treat it more actively and acutely as well. And after the 12 weeks, the fetal pituitary thyroid axis starts functioning. And this is what I meant by your HCG. This primarily happens in the first trimester, so the HCG peak happens around the 8 to 12 week mark, where the HCG stimulates the TSH receptor, and there is a surge in thyroid hormone activity leading to a marginal increase in free T3 and free T4 with the dip in TSH. And some of these patients may have even up to less 0.01 levels of TSH, which might surprise us sometimes. These patients have to be examined thoroughly, do a good clinical history, and that's what would differentiate If in doubt, a thyroid TSH receptor antibody can also help you, but that's not needed in most patients. I would say a good clinical history and examination is all is enough for these patients, and a repeat test at 4 weeks would be just sufficient to confirm this. What happens with maternal hypothyroidism? There is no doubt that overt hypothyroidism causes a lot of damage. And I've put on various studies. These are data from different studies. It uses, these data varies for spontaneous abortion between 10 to 70% in subclinical disease, and spontaneous abortion happens in 60% of individuals with overt hypothyroidism, which means you've got significant hypothyroidism with raised TSH more than 10. Preeclampsia, abruption, stillbirth, anemia, postpartum hemorrhage, and preterm birth are all problems due to hypothyroidism, maternal hypothyroidism, that is. And looking into more detail, pregnancy loss is very, very difficult because most of the pregnancy losses we have is in the first trimester or even before the patient themselves recognize, and they may have raised TSH. And it's, there is a continuous relationship between your TSH and pregnancy loss. So the higher the TSH, the higher the likelihood that you're going to lose the pregnancy. But we do not recommend MTP as a therapy for this. We try to normalize thyroid function tests as soon as possible or as soon as the diagnosis is made. So premature delivery is another complication leading to infant mortality or even pregnancy losses, and there is a substantial morbidity even in later in life. So again, this is also a continuum-based therapy. So the higher the TSH, the higher the chances of premature delivery, and patients who have ATPO antibody positive are at a higher risk. Patients are also at a higher risk of hypertensive disorders, low birth weight babies, and then last but not the least, the IQ loss which was detected by the NEJM paper, which is put off to, this was a paper, retrospective paper, where they compared with hypothyroid mothers with normal mothers and children who were untreated, who had subclinical disease, had an average IQ loss about 6 to 8 units in comparison to patients who had been appropriately managed with thyroxine doses. So when compared to the patients who are not on treatment, if you compare two scores, when you compare the IQ scores of children of untreated mothers, there is 7 points lower than the control. The children of the women who were born with a higher TSH, again, had a higher percentage who were running into this problem. So this was the primary aim of treating subclinical hypothyroidism in individuals. Who should we screen for this? And there are a particular group of individuals who are at risk. Patients who had a history of thyroid abnormalities in the past, patients greater than age of 30 years as such in diabetes, family history of thyroid abnormalities, patients who have goiter. We assume most goiters are autoimmune unless or until the patients are on a low iodine diet. Symptoms, signs, and suggestive of thyroid disease. Anybody who has got type 1 diabetes, anybody who has got a history of other autoimmune conditions like rheumatoid arthritis, subfertility, previous head and neck radiation, and history of miscarriage or preterm delivery. So these are the individuals who should be ideally screened mandatorily. There is various guidelines which have been advising us about when to screen and what to screen, and there are too many guidelines, but as I said earlier, the Indian national guidelines, mainly endorsed by the Indian Thyroid Society, recommends measuring TSH levels in all pregnant women at the first visit, because most of our population are ideally have not had a thyroid test in the past. So ideally, in the first pregnancy visit, they should be screened with a free T4 and TSH or a total hormone check, whichever is available. Evidence for this is limited, but as I said, universal screening has been advocated only in our country because of the differences between our Caucasian counterparts and us. Again, there is a high-risk group here who needs more particular care, and these should include, these patients are people with history of thyroid autoimmune disorders, family history of thyroid disease, women with goiter or with a history of miscarriage or preterm delivery. So I'll just skip this. We've been discussing hypothyroidism is not an issue at all, but there has been a couple of studies who have complicated matters or confused us, and these two studies, which were the Negro et al. Paper for universal screening and case finding, and the John Lazarus paper, which was the CAT study, which was controlled antenatal thyroid screening. And I'm just putting it just for information here. And the maternal outcomes in these universal screens and case finding studies did not offer any benefit, and this was the basis of the recommendation of the Western guidelines not offering universal screening. This is another study which showed that people who have got autoimmunity and at the risk of miscarriage or a previous history of miscarriage do benefit a lot from therapy with thyroxine, even whether it's a 25 microgram dose or your lower thyroxine. I'm sure Dr. Sriram will touch upon this more, but patients who have got subclinical disease may benefit and can reduce their pregnancy loss or their risk of pregnancy complications just by taking a small dose of thyroxine. I'll just skip this due to time. So the other thing is we find a lot of women at the end of pregnancy or in the second trimester with isolated low free T4 values or even total T4 values. And universally, it has been agreed that these are due to, I would say, variations in measurements, and there is no study. If the patient has got a normal TSH and a low free T4, these patients don't need any treatment on its own. So this will be addressed by Dr. Sriram. Our next part of the talk would be on the current guidelines of management of thyroid dysfunction in pregnancy and postpartum. And there are specific recommendations given by these organizations, especially the American Thyroid Association. Oral thyroxine therapy is not debated anywhere. Oral thyroxine therapy for people with hypothyroidism is mandatory, which negates all risk of fetal loss, premature birth, and this is more appropriate even for patients with positive antibodies. So women who are already receiving thyroid replacement therapy should increase their therapy by 25 to 30% while they're pregnant. And people who you think are a higher risk and have got autoimmunity should be monitored closely. In the first trimester, most of the reference ranges, we would like to keep it at less than 2.5 and up to 3 in the second trimester and the third trimester. As I said, treatment is not needed with isolated free T4 levels, and a minimum suggested iodine intake is around 250 micrograms per patient. Data currently, according to the American Thyroid Association, is insufficient for universal screening, but during the postpartum phase, people have to be monitored more closely. So if you've got antibody positivity, then they are at a high risk. If they've got levels above 10, they need to be treated. If they've got negative antibodies, then they don't need to be treated. So how do we adjust levothyroxine treatment? If the TSH is greater than 10, then increase the dose by 50 micrograms. If the TSH is more than 20, you might need a further increase, and if the TSH is greater than 20, you might want to put it further. Still, there is a significant proportion of people who are not well treated in pregnancy, about 40% who are above target, so we need to address that. And people who have had surgery will need up to a 50% increase in dosage for patients who have had thyroidectomy, for thyroid cancers, or any other surgery in the thyroid. One word of caution is if you're giving iron, please do not give it within 4 hours with your thyroxine. The absorption will go down. The same applies to calcium, so preferably calcium at lunchtime and iron at bedtime. And people with postpartum, you can certainly stop after, if somebody is on a very low dose of thyroxine, 25 or 50 micrograms, it's very safe to stop as long as they do not have risk factors post-pregnancy. One word of caution about iodine status. A lot of people have started following the Himalayan salt, pink salts and things, and pregnancy is one time where you are at a highly increased risk of iodine insufficiency, and make sure that your patient is taking iodized salt. So that I'll So that's the answer, because iodine is an important mineral and it is one of the most common causes of mental retardation and short stature elsewhere as well. So in summary, pre-conception, we want to optimize the therapy if possible and if there is an opportunity. Once the pregnancy is confirmed, there will be certainly an increase of 30 to 50% from the pre-conception dose. Our target levels for TSH is less than 2.5 in the first trimester, less than 3 later in the pregnancy. The reason being that is we do not have pregnancy-specific reference ranges in our country for most laboratory testing. So this is where we stick to the reference ranges, and after delivery, go back to your pre-pregnancy dosage and assess your thyroid function in 6 weeks postpartum. Patients who have had surgery or post-radiation, which is primarily radioactive iodine, will need higher doses of therapy. Thank you so much for listening.
Thank you, sir, for your excellent, crystal clear lecture on this subject. The take-home points: we have to screen and manage hypothyroidism in pregnancy, which is trimester specific. The dosage has to be adjusted accordingly. During the first half of pregnancy, the TSH values has to be monitored every 4 weeks, and in the second half, every 2 months, the TSH values to be screened according to the FOXY guidelines, or at least in the second trimester, once in 28 weeks, we have to screen. And we routinely screen the newborn for congenital hypothyroidism on day 4 of delivery. Routinely, we do the thyroid profile on day 4 after birth. And regarding the universal screening and targeted screening, we in our setup routinely screen the woman for thyroid profile at the first antenatal visit or as soon as the pregnancy is confirmed. Thank you, sir.
Pleasant morning to all. And it is really a great privilege to introduce Dr. Sriram Mahadevan. He graduated from Stanley Medical College and is postgraduate Institute of Medical Education and Research, Chandigarh, and presently professor and head of the Department of Endocrinology, Sri Ramachandra Institute of Higher Education, and consultant endocrinologist, Sundaram Medical Foundation. And affiliations, the postgraduate training in the UK and internationally accredited training in internal medicine and endocrinology.
Sorry
and
to
achievements.
interrupt. That's a copy-paste problem.
Okay, sir. So
I think
it is the executive
many
committee.
of our colleagues know me.
Yes.
I think you, Muthukumaran naduvula paste maatanga. You just leave it there.
So really it is
Thank you.
regarding this anti-TPO antibody positivity in youth-rider women.
Thanks,
really
madam.
it is management issues we are having really a lot of doubts.
Yeah.
So over to you, sir.
I'm really thankful to you, but the problem is the organizer is staring at me again and again. We are already learning too late. And already Muthukumaran previous speaker has given some points which are really controversial and needs a lot of discussion, and I'm going to add to that confusion and hopefully give some clarity, some take-home points which will be practical for our management tomorrow. Based on what I understand from this literature, the review is heavily based on all guidelines and all articles related to the guidelines, and original studies from India, especially on this issue of euthyroid antibody positivity, is literally lacking. And so I will give you some background on the thyroid antibodies and the link between the positivity or elevated titers of these antibodies and pregnancy outcomes. And very important question is, does intervention in some form benefit in the outcome? And how do we take the guidelines? So we know there are basically 3 main antibodies. For our discussion today, it will hover around only the thyroperoxidase antibody. And these antibodies are polyclonal, predominantly IgG. By that we mean that they will cross the placenta. A simple way to remember is these antibodies are thyroid inflammation specific, thyroid disorder specific illa. Something like prostate specific antigen is prostate specific, not prostate cancer specific. So don't use it for cancer screening, in that sense. And thyroglobulin also not a marker for thyroid cancer. It is thyroid, any follicular cell in thyroid producing thyroglobulin. Similarly, these antibodies, if your gland has undergone some damage during your childhood, some inflammation, or you have a genetic predisposition that has been mentioned here, you will form antibodies against various antigens in the thyroid, and one of the most common antigen against which this is formed is thyroperoxidase, also called thyroid microsomal antibody. And thyroglobulin antibody is also common, but by convention, and because a lot of studies have been done with TPO, we use TPO antibody. So some clarity? So don't use only TPO antibody. If you are using as a panel, do together, but go by TPO antibody. And whatever literature I went through, if the titer is above the limits of the lab, take it as positive. It is not like 1 in 1 lakh will have a higher prevalence of something versus 1 in 50,000. Do not check it again and again to see whether it is coming down. These are all common things we do many times. Patient get worried. The number comes as 1 in 1,30,000 and all. If you dilute and do it. So these antibodies, because they have been shown to have a link to the inflammation, which I already mentioned, and like TSH, it also has a lot of other factors which are controlling these antibodies. For example, here, extremes of ages, pregnancy is an enormous stress. So any postpartum lady will have more likely to have formed antibodies. So before second pregnancy, she may have. And other immunomodulating conditions, recovering from another immunosuppressive therapy, like the heart therapy will cause immune reconstitution. And whenever you lose the thyroid gland by radioiodine, your titers will come down. All these have to be kept in mind while interpreting. And in normal population, you see here from the Wickham survey in early 1970s, roughly around 6%. With changes in titers and the antibodies, it is up to anywhere from 10 to 15%. And recently, there are quite a few papers from India. So roughly around 10 to 15% of normal population will have antibody positivity, out of which a small subset will develop thyroid disorders. And in pregnancy, remember this mantra. In general, this is an immunotolerant environment. Otherwise, a female cannot have a XY chromosome male baby inside. No, this is a very simple way of remembering. How can she carry a fetus? So, immunosuppressive state. And that's why all autoimmune disorders actually go into some remission during at least the second half of pregnancy, and nicely exhibited even in this cartoon. You see the thyroid specific antibodies come down, and again, like immune reconstitution, it gets elevated. That's why the postpartum thyroid disorders have a immune based mechanism here. And IgG antibodies are most predominant. They traverse the placenta, and that's why they will have an impact. I am not discussing Graves' disease today. Most often I am discussing only TPO antibody positivity. And if there is a TSH receptor antibody, that can very well go inside and cause even fetal thyrotoxicosis. But they are a mixture of both stimulating and blocking antibodies, and TPO antibodies, predominantly IgG, can cross. To the extent that you will have these TSH functions. You see here, interestingly, is more in the first trimester in antibody positive people when compared. In the ஒரு கான்செப்டுக்காக தான் இவ்வளோ டிஸ்கஷன். What does this thyroid antibody positivity mean? Very oversimplified way of saying is there is some problem in the thyroid which makes a relative deficiency of thyroid in a normal person also probably. On the top of it, you become pregnant, your demand is more. So this already antibody positive lady with a minor, a first hit Mari, there is a problem in the thyroid, not able to produce enough thyroxine. First trimester, HCG, stress, all these things have been told already. So the demand is more. Maybe this antibody positive thyroid is not able to cope up with the demand. So they may be subtly deficient in thyroxine. That's the whole logic behind why thyroxine is given and not steroids are given to suppress this. So any organ-specific antibody treater, you give immunosuppressive therapy, target antibody therapy, that's not thing. So in pregnancy also they have done antibody positivity studies, and anywhere from 10 to 15%. Most of them are Caucasian studies, and depending on which clinic you study, it may be more. And the whole idea is to tell you that you may have normal people getting pregnant with antibody positivity. That alone will not be a stress, a subset of them will have. So these are all the mechanisms proposed taken up from various reviews. The first one I have put here is the most easiest way to understand. All other things are more of an animal-based informations which may or may not have clinical significance. So we assume, or there is enough reason to believe, and I have already shown you the TSH increasing when compared to TPO negative versus TPO antibody positive people. So mild thyroid hypothyroidism happens in many people. Mild means the TSH going within the normal reference range. That's why this all discussions on 2.5 to 4, whether antibody positivity, etc. are coming up. So does thyroid antibodies affect pregnancy outcomes? I think Dr. Muthukumaran showed enough paper on TSH elevation. Here I am discussing euthyroid. In this case, I have to already, a disclaimer I already say, for this discussion purpose, keep TSH as less than 2.5 as normal. Let us not go into that 4 discussion today. 2.5 is normal, most of them are Caucasian data. So less than 2.5, TPO antibody positivity, what will I do? That's what is the next few slides is going to tell you. Lot of information. These 2-3 names like Haddo et al., Glenor et al., Stagnaro, Green et al., thiruppi avanga papers now. Everywhere they have done a lot of studies to tell us that there is a definite association between antibody and these people you see here, TSH getting elevated through more than 4 during the pregnancy. This Negro et al., they have done a lot of work on this. Again, TSH increasing more than limits of the thing. And we know the background biological basis also. So for every reason to believe that the antibody may interfere, especially during pregnancy in a thyroid and cause a mild thyroid dysfunction, and hence the recommendation very clearly, if you already have a patient who has got an antibody positivity, you know the report. We are not asking to do the report in every normal pregnant lady and find out that 10 to 15% of normal people having positivity. If you have a positive report, at least monitor the TSH. If less than 2.5 in the first trimester, which is the most near sure short way of saying that the thyroid is functioning normally if it is less than 2.5, and if not, monitor at least. If you are not sure of the lab, etc., you repeat it. And please monitor it throughout pregnancy is the recommendation. And as has been discussed with TSH elevation, euthyroid positive people, TPO positive people have been shown to, in 2-3 meta-analysis of 3-4 studies put together, those small studies, that they have more chances of spontaneous pregnancy loss. First and second trimester losses are more. These are all observational studies. This is one large meta-analysis to show that the TPO antibody positivity people have more chances of miscarriages. This is one clear association. Premature delivery also, there is reasonable data, and again the same names you see here, Negro and other people. We will see that again there is a reasonable, strong basis to say that TPO antibody positive but euthyroid mothers have a relatively higher risk of these complications. In addition to that, there is some association between perinatal death, placental abruption, postpartum depression, etc. So what do we understand? இந்த மாதிரி ஸ்டடி போட்டாலே அதுவும் தலையை சுத்தும். These are all association studies, like TSH also. Proof of the pudding is in its eating. So that's because they are nicely pooled meta-analysis. We understand that there is a strong association between elevated thyroperoxidase antibody in euthyroid mothers causing problems. But is it the real cause? I already mentioned that they are not causative antibodies. They may be just there, but they are getting clearly associated, causing some dysfunction at the placental level, zona pellucida level, or at the thyroid level. So how to prove that they are actually causing? You treat with thyroxine and see whether these complications are improving. And that's where the problem starts. What are the studies showing? This is euthyroid acid benefit. This is one of the largest study done. And on this is called the tablet study. So for everything we have the gospel, this is randomized control trial. Because miscarriages are the most important association of TPO antibody, these studies take the highest risk of TPO antibody people and show that in euthyroid TPO positive people who have an history of miscarriage and due to that an infertility, around 476 women were treated. This is a UK study where a 50 microgram of thyroxine was a standard dose given to all these women. And what did they show? No big difference in the pregnancy outcomes. The p-values are not significant for miscarriages also, which was the primary aim of the study. Immediately we should not jump. Is it the final answer? There are a lot of flaws. See, every study will have limitation. What are the limitations? In UK, booking is done after 12 weeks. So that itself is a limitation. So our people, you all know, our senior gynecologists sitting here, many people will come at 7th week, 8th week itself. Starting thyroxine at 7th, 8th week, which is the most important period, mukyama, illa 13, 14 weeks kapram ஆரம்பிச்ச இந்த study mukyama. இதுதான் நம்ம கேட்கணும். Then everybody was given 50 microgram thyroxine only as a standard dose, but we titrate. It's not like everybody will require only one dose. So these are also, and all other antibodies which are the other autoimmune conditions which are associated, they are not ruled out in this study. They presume that thyroxine was the only antibody here. So limitations become the arena for further research in this, and the conclusion of this study is correct according to this study. In this study, they show that a standard dose of 50 microgram levothyroxine given to euthyroid, TPO positive to UK women with previous history of miscarriage infertility did not show anything in that study for the 2 years time. Whether it will be the same thing repeated in India here, and when you have a given patient here, that's different. So lack of evidence is not a gospel equivalent to saying that it is evidence for lack of benefit. This is the other way of putting it. So then so this fallacy has been addressed in the next study. This is published just 2 months back in Lancet and Diabetes Endocrinology, which is T4 life trial. In the trial will be repeated in all thyroid talks everywhere. Phase 3 trial where 2 important things have been addressed which were the limitations in the previous study. And that is, this is also a big study in Belgium, Denmark, Netherlands. So it's a multi-centric international study. Women TPO positive with more than 2 pregnancy losses. So by our usual thyroidology definition, they are high-risk people. And they gave thyroxine to these people, and they ruled out, you see, so many other autoimmune conditions as cause of miscarriages, which was not done in the previous study. And they gave a titrated dose of 50 microgram, not only 50, they gave titrated doses, keep the TSH below the recommended doses in those hospitals, and again showed in these high-risk people that the live birth is the most important definition, not just conceiving around it. So they showed that again it was not significantly different between the treated and the other group. So now the problem, you had an association biologically proven by the previous association studies, pooled analysis. However, the prospective interventional studies are not showing big benefit. Does it mean to say that we will never give thyroxine to all our people? That's, you have to individualize. This is the Kaplan-Meier curve of live bleeding. So you see both are overlapping on one another, means there is no significant difference. And again to show that in people with high risk recurrent pregnancy loss, in spite of excluding all other causes, TPO antibody positive mothers with euthyroid mothers, we are not getting a good benefit out of thyroxine therapy. Then to add to more confusion, they said, okay, in spite of that, we will decide to give thyroxine. No harm, 25-50 microgram thyroxine. Usually we all know that may not harm the baby, and you should know. This is also an important parameter to remember. Thyroid hyperthyroid, the pregnancy is a mild thyrotoxic state, especially in the first trimester. You saw the TSH is always low. So putting all this together, to add to confusion, see, this is one paper again from the European people, 2015. Haddo et al., Dr. Muthukumaran showed that subclinical hypothyroid mothers not getting treated, the baby had an IQ point lower by 6 to 8 units or 7 units exactly. Here, people who had a TSH which is suppressed in the first and second trimester, brain volume morphology was different in these people as studied by MRI and other things. But that's how science goes, you know. You have to take these points together. So tomorrow, so don't over-treat also is what they are trying to convey from this. But this has to be replicated in number of other studies. This is not a clinical study. These are all the children who underwent MRI, and they went back and showed that they were all the mothers who had TSH less than 0.1 in the first trimester. So this is also just to remember that I will not treat everybody. That's another. So that is why the guidelines are varying. With so much of conflicting information coming from different guidelines, these ACOG people already in GDM, I'm sure we were all sitting in Hall B, in Hall A, the discussion was happening. I'm sure there would have been a lot of differences of opinion between the Indian. Similarly, we have the American College of Obstetric Gynecology and the American Thyroid Association, some discrepancy. Because 2017 was the last guideline published by ATA, and today is almost 5 years. ஆட்சியாக இருந்தால் கூட மாறி இருக்கும் அந்த நேரத்துக்கு. ஆனால் guideline there is so much of new information has happened. It's high time that the new guideline incorporating all the new information has to come, and that's why the ACOG, this Clinical Thyroid Journal, came up with this interesting final table information, which will be useful to go through for our final message from this talk. I have given you confusing information. First part I showed you that there is a clear association between TPO positivity and TSH normal people. When I say normal, in pregnancy and pre-pregnancy less than 2.5, still having adverse outcomes. You treated big randomized study, 2 major studies are not showing benefit in the high risk people. That means there is something we have to go more than this. Then should we treat or not treat? Be safe, and that's why you see the ACOG people are not agreeing to treat. TPO positive, TSH between 2.5 and reference range, TPO, but this is the place we are discussing here. They are not agreeing, but still ATA 2017, these are all not agreeing because they are incorporating some of the information of this tablet and other studies also into this. So my take-home message from this, whatever I understood, is you individualize. How do I individualize? Please, I will err on the ATA side. In spite of all this, we know that iodine deficiency will be a problem, obesity will be a problem. I will know that our TSH assays are not the best. I cannot be repeating every 4 weekly and all, it's not possible. They are saying that if your TPO is positive and TSH is in the normal range, you monitor. How many of us will monitor? Every trimester we will take free T4 TSH also. Then in the second trimester she comes with a TSH of 3.8, suppose, which is above the limit but below 4. Will you leave her? Then they will say, no, Ponavati in that area, 2.6 in the 3, but the patient will ask you 100 questions. So my take-home practical message from all this is, that's what I personally feel. I'm opening a Pandora's box. I know I will treat these people, especially people with high risk, people with goiter, background autoimmunity, TPO positivity, even if TSH normal. There seems to be some logic somewhere. Just because 2 big trials done specifically in special subgroup of high risk people did not show benefit, will not be my take on this. And I back up on ATA, and I agree with them, at least on this thing, that maybe we should consider treatment in many of our women. This ACOG is, they are too strict here. In fact, see here, they are not treating even TSH above the limits of normal, only if free T4 is low. This we don't do. Free T4 assays are highly unreliable. If TSH above 4, you have to treat first trimester. So the guidelines are formed by few people, like many of us sitting here, and sometimes we have to take with a pinch of salt. So guidelines are guiding us in a manner, but treatment is what I will consider in most of these people, in high-risk people. Thank you very much for your kind attention, and if there are any questions, I'll take up.
Thank you, sir, for enlightening on TPO antibody.